Good evening. Today we shall be dealing with ECG case number 14 in our ECG series. The title is Winter is Coming. Now, if you have not been living under a rock for the past 9 years, you would know that this is from the HBO hit series, The Game of Thrones. Let's go straight to the case. This is a 38-year-old, while competing in a marathon, developed sudden onset of chest pain with severe dyspnea. His O2 sats was 77% on oxygen. Now, this was his ECG. You can have a look at this ECG. If required, you can press the pause button to gain further time, or you can go ahead. Having a look at the ECG, you can see the age is typed wrong. It's 638, not 68. A lot of diagnosis is written, but now don't rely on the ECG machine for the diagnosis. Rely on your judgment. The intervals probably would be accurate, but don't rely on the diagnosis. So let's see what the ER physician did. The patient was diagnosed to have acute pulmonary edema and was intubated and ventilated. Now we don't have further clinical information regarding the status of his lungs, whether there was crepitations or not. Let's assume that this was a right diagnosis and that he indeed had acute pulmonary edema. He was sedated and paralyzed as he was fighting the ventilator. He was diagnosed to have hyperkalemia based on the tall T waves, probably due to rhabdomyolysis. Now, unaccustomed physical activity like running a marathon can cause rhabdomyolysis, which can lead to hyperkalemia. So he was given calcium gluconate to stabilize the myocardial membrane, insulin dextrose and nebulization with salbutamol to reduce the potassium levels. The investigations came as urea 31, creatinine 0.8 and potassium 4.1. The potassium levels are normal. Now keep in mind this was taken before the administration of all your anti-hyperkalemic measures. So at this time the ER physician decided to review the diagnosis and he took another ECG. ECG done 2 hours later since admission showed a new onset of a right bundle branch block with ST elevations in V1 to V5, ST depressions in 2-3 AVF. Now this is your classical proximal LAD occlusion leading to an anterior wall MI, which signifies a large area of myocardium at risk. You localize it in the proximal LAD due to the right bundle as well as ST depressions in 2-3 AVF. Now what was missed? We actually missed the D Winters T waves. Now this was clearly seen in V3 and V4. The D Winters T waves are an upsloping ST depression which goes rapidly into a tall prominent T waves, a rocket-like T waves. So upsloping ST depressions usually are non-pathological. The exception is the D Winters T wave. Upsloping ST depressions generally don't localize. The exceptions are D Winters T waves. So you can clearly see the D Winters T wave in V3. You can see the ST depression, which is upsloping, going rapidly into a tall T wave. This was the original ECG. You can see there are 2 signs which have been missed. One is you can see a loss of normal precaudal T wave balance. Look at the T wave in V1. It should always be smaller than the T wave in V6. This is normal precaudal T wave balance. So you can see the T wave in V1 is taller than in V6. So you have a loss of normal precaudal T wave balance. This is suggestive of an evolving anterior wall MI. And in V3, V4, you can see the T Winters T waves, which are very definitive of an anterior wall MI. So 2 signs were missed. One is a loss of normal precaudal T wave balance, which is suggestive of an anterior wall MI, and the D Winters T wave, which is definitive of an anterior wall MI. So you see signs, loss of normal precaudal T wave balance and D Winters T waves. Both of these were missed by the treating physician. Treat the patient, not the ECG. This is what happened. The ECG hyperkalemia does not explain the chest pain or the pulmonary edema. In a patient with sepsis or shock or renal failure, tall T waves are mostly due to hyperkalemia. However, in acute chest pain, it's most likely the D Winters sign. And also, tall T waves of hyperkalemia are usually narrow, whereas the D Winters T waves are usually not. So treat the patient, not the ECG. So D Winters T waves were described recently, as recent as 2008 by D Winter in NEJM, which is the New England Journal of Medicine, as a new ECG sign of proximal LAD occlusion. The first author was De Winter, the second author was Verouden. Verouden subsequently studied this extensively in great detail and published this analysis in 2009. And Hein J.J. Wellens, the same Wellens as in Wellens syndrome. It signifies a proximal LAD occlusion which is reperfused. So Wellens was very involved in proximal LAD. So he described Wellens syndrome, which was a reperfused LAD, and also he was involved in an acute occlusion of the LAD as in De Winter's waves. So De Winter's offers a peek into the widowmaker. Was seen in approximately 2% of LAD occlusions. highly suggestive of proximal LED occlusion, around a 95% proximal positive predictive value. So you can see three different studies, all which show a range of 95 to 100%. So if you see a D-Winters T wave, in all likelihood, you are dealing with a proximal LED occlusion and an anterior wall MI. This is considered as STEMI equivalent, as we don't have an ST elevation, but it implies that the artery is occluded. So how does D-Winters T wave differ from hyperacute T waves? Now, D-Winters also may mimic a hyperacute T waves. Hyperacute T waves last for minutes. D-Winters T waves may last for hours until reperfusion, or may evolve into a STEMI and follow its usual evolutionary pattern. So D-Winters may remain static as such and until reperfusion is achieved, or may evolve into a STEMI and follow its usual evolutionary pattern as it did in our case. Originally, De-Winter believed that his De-Winter's T waves are usually static. However, subsequently, we have also shown evolutionary patterns also. So Verouden, the second author, studied De-Winter's waves extensively and came out with his analysis in 2009, the Heart Journal. He found that patients with the De-Winter's pattern were younger, more likely to be male, and had higher incidence of hypercholesteremia when compared to classical STEMI patients. It usually manifests 90 to 100 minutes after symptom onset. So if the LAD is occluded, De-Winter's waves manifest 90 to 100 minutes later. And since we don't have frank ST elevation, usually there's a longer time to reperfusion because of lack of recognition. And there is significant LV dysfunction due to delayed recognition. So not only do we not identify it, we usually don't treat it as well also. We look for ST elevations in the ECG. Our minds are not tuned to ST depression. So there are three different types of De-Winters. The J point is depressed with an upsloping ST elevation and going into a tall T wave. Here the J point is depressed, however not as much, just barely about half millimeter. And you have a horizontal ST segment followed by the rapid development of upright T waves. And the last one, you have no ST depression, just hyperacute T waves. The exact mechanism of De-Winters, we don't know. We don't know how De-Winters occurs. De-Winter himself proposed that it was endocardial conduction delay due to anatomical variation of Purkinje fibers. However, a more logical explanation would be inactivation of ATP-sensitive sodium-potassium ATPs. This is also the mechanism of hyperacute T waves. So what happens normally is you have the sodium-potassium ATPase channel, which pumps out sodium and takes in potassium. Now, when the LAD is occluded, in the area supplied by the LAD, there is decrease in ATP. Your sodium-potassium ATPase stops working. There is extracellular hyperkalemia. Now, what happens when there is hyperkalemia? There is tall T waves. This is one of the mechanisms of tall T waves occurring in MI, that is failure of the sodium-potassium ATPase. Hence, potassium becomes predominantly extracellular, causing the tall T waves due to hyperkalemia. So De-Winter's T wave indicates an occluded LAD. You take up the patient for an immediate angiogram. Valence T waves are occluded and now spontaneously reopened LAD. You can do a CAG before discharge. Now, Valence T waves indicate reperfused LAD. So you can wait for some time and take them up before discharge. While De-Winters actually indicates you are dealing with an acute anterior wall MI, you take up the patient immediately for a CAG. This is Valence T wave. At the time of pain, you have pseudonormalization. And when the patient is pain-free, that is reperfused, you have T inversions in the anterior leads. For further details, please look at the Valence video. Now, can I thrombolyze with a De-Winters pattern? We don't have guidelines for this. It is controversial as we don't have proper guidelines, and the jury is still open whether we need to do thrombolysis or avoid thrombolysis in De-Winters sign. Now, if you don't have a cath lab, you can probably thrombolyze. However, we don't have data, and if you do have a cath lab, please take him up for an angiogram and see what's going on in the coronaries. The thrombolysis is a question mark. Again, another example of De-Winters waves where you can see a marked ST depression going into a tall T wave. So a bit of history. De-Winters T wave was described in 2008 by De-Winter. Second author was Verouden. Third author was Valence. However, Valence came, the paper of Valence syndrome came in the American Heart Journal in 1982. Heinz J.J. Valence was a giant in electrophysiology and electrocardiology. He was called the giant of Maastricht. He was a Dutch cardiologist. for his contributions to cardiology. He died recently in 2020. So this is a good opportunity to remember him. De Winter's T waves, although described by De Winter in 2008, this was further described back in 1947 in the American Heart Journal by William Dressler. So he studied MI in the early stages, what happens to MI once the artery is occluded, and he found that De Winter's T waves occur in one patient in his study. So this was his study. You can see the De Winter's pattern evolving into an anterior MI. He described this in one patient. So, however, some people describe this as De Winter Dressler's T waves. So, Dressler contributed to the Dressler's beat, which are fusion beat in VT, and Dressler syndrome, which is a post-MI pericarditis. So, he described both of these syndromes also. So, he also played a role in pacemaker development. He was against pacemakers being implanted, but later he published a lot of articles regarding implantation of pacemakers. So, what are the take-home messages? De Winter's T waves, they are rare, easily missed, and should be considered as a STEMI equivalent. Although there is no frank ST elevation as such, it implies an occluded LAD. So, a proximal LAD is occluded. You take up the patient with the cath lab immediately, treat it as an anterior wall MI. Thrombolysis, we still have no data, and we are still awaiting evidence. So, De Winter's T waves are easily missed, they signify proximal LAD occlusion and should be taken up for a primary PSA. Thrombolysis, we still await data. So if you like these videos, please like, share, and subscribe, and press the bell icon to get notified when a new video uploads. Thank you.